exciting new approaches and medications. So when we talk about chronic heart failure, certainly this refers to systolic and diastolic heart failure. There will be a whole presentation this morning on heart failure with preserved ejection fraction. So I will not go into great detail, but I think when we think about the treatment of these patients, it's always instructive to look at the pressure-volume relationships. And I think one of the struggles that we have conceptually, especially in heart failure with preserved ejection fraction, always has to do with the dissociation between pressure and volume. And oftentimes we know the patient has very high pressure, but there's not a good correlation between pressure and volume from the standpoint that some patients can be diuresed or put on a vasodilator and quickly modulate a specific parameter, whether that's pressure or volume, and we can get into trouble rapidly with systemic blood pressure. So I actually think I'm glad that one of my colleagues is going to speak on heart failure with preserved ejection fraction, because it's an extremely difficult group of patients to manage. So we talked about risk stratification already to some degree, but I think in the context of this lecture, I want to mention the staging classification that was developed a few years back by the American College of Cardiology, and it is now embedded into the AHA-ACC guidelines. And I have a good feeling that in the not too distant future, the Heart Failure Society of America, which includes North and South America, obviously, may join forces with ACC and AHA to present one guideline document from this side of the Atlantic, which is pretty well aligned actually with the European Society guidelines. So where we have spent a lot of time is in stage D, or refractory heart failure. Most of this lecture will revolve around stage B and stage C. So essentially any patient that's admitted with acute decompensated heart failure is going to be a stage C heart failure. So a patient with LV dysfunction who has never, quote unquote, been symptomatic, that would be a stage B. And then the whole group of stage A is really a preventive cardiology. This is our efforts in patients with oncologic diseases, coronary disease, hypertension, diabetes, that we hope will never develop symptomatic heart failure if we can effectively treat their underlying disease. So emphasized in the most recent guidelines that were published in 2013, again, this is low tech, but the bedside evaluation is very much emphasized as far as walking away from the bedside with knowledge of the jugular venous pressure. Is the patient edematous? Do they have a history of orthopnea? Family history is highly essential, and we'll talk a little bit about risk scores and specifically biomarkers and how this all falls in. So there are many different biomarkers. I don't have time to go through all of them, but I'm just going to focus on natriuretic peptides, which are the most commonly used. This is the biomarker. So essentially, if you ask me what biomarkers do we follow at the Cleveland Clinic in our heart failure patients, there's only one, and that's N-terminal BNP. We do often check troponin in the setting of acute decompensated heart failure, but BNP is really the only biomarker. We don't follow galactin, we don't follow STS2, only BNP at this time. And I think that the audience is probably well aware that BNP is a substance, a peptide that is released by the cardiac atria as well as ventricular tissue, and it's in response to stretch, hypoxia, hormonal and cytokines, and corin, which cleaves pro-BNP, then results in BNP and N-terminal BNP. N-terminal BNP is probably the platform that is used most often in the United States now, primarily due to cost, stability, and ease of the platform to make this widely available. The problem with this particular biomarker, and it's not a problem, it's just the fact that we have to recognize its limitations, is that there are cardiac sources, but there are also non-cardiac sources. So on any given patient with an elevated BNP, this always has to be put into context. What about the diagnostic accuracies of the natriuretic peptides? And what you can see on this, whether you're looking at BNP or N-terminal BNP, as far as a rule-out diagnosis, so say in the setting of an emergency room, the negative predictive value is quite high. And there are 8 specific cutoffs that are used primarily in clinical trials. There are always caveats, so I would caution anyone that is suspicious of the diagnosis of heart failure, even in the absence of an elevated BNP, don't necessarily stop your evaluation. If you're the cardiologist looking at this patient, and I think the burden of responsibility is to convince oneself that there's no underlying structural heart disease. As far as what the guidelines say for the diagnosis and exclusion of heart failure and for prognosis, it's a class 1 level A. And notice that for achieving guideline-directed medical therapy, ambulatory, which is what we're going to talk a little bit about today, it's a 2A level of evidence B. So the bottom line is, as far as in the US guidelines, there's really not strong advocacy yet based on the current body of evidence to use BNP to guide your treatment. Having said that, there's lots of data that has been generated as far as algorithms that have been used in clinical trials and can be used in your clinic depending on your biases to use BNP, and to use it in a somewhat preemptive manner. So for example, if you look at the second category here, stable ambulatory heart failure, greater than a 30% rise in N-terminal BNP, the strategy is to intensify the treatment. So we are moving gradually more toward a preemptive augmentation of therapy, whether it's based on a BNP trigger or based upon pulmonary artery pressure sensors. So the patient may say to the physician, I'm not short of breath, I don't have edema, but if the pressures have risen and or the BNP levels are high, there's increasing momentum that this should be used as a strategy, and this can result in keeping patients out of the hospital. I would submit that the body of evidence is not yet satisfactory that this has made it in the US to a level 1, level A, stage A. There's currently a large NIH trial underway in the US called Guide It, which is a BNP-directed therapy for patients that have been admitted to the hospital with acute decompensated heart failure. They have to have a BNP level greater than 2,000. The last category that I want to mention is how can you use BNP to predict if your patient will be readmitted to the hospital. And again, this is a growing body of evidence that if your patient's BNP has fallen significantly, they may have a lower risk of readmission. And again, this is not a standard of care. It's not in the guidelines yet in the US or at the Cleveland Clinic, but this is a very active area of investigation. So this is one study published in JAMA last year, which was BNP-guided multidisciplinary intervention to prevent heart failure, the so-called STOP-HF study. And the primary endpoint was prevalence of heart failure, hospitalization, etc. And what you can see is that in the patients that had a BNP-directed strategy, there was a reduction in major adverse cardiac events. So this remains a very active area of investigation, and my prediction is that with time and more evidence, BNP will find a role in guiding therapy and make it to a level of evidence A in the guidelines. So when we set our goals for patients with chronic heart failure, be it systolic or diastolic, the cornerstones are relieving congestion, slowing the progression of the disease. That's where the specific neurohormonal antagonists come in, cardiac resynchronization therapy, preserving end organs, avoiding sudden death. Stage B, I'm just going to pass by very quickly, but I want to emphasize the importance that whether it's the heart failure cardiologist or the general cardiologist, especially in the post-MI patient and the post-CABG patient, the importance of initiating guideline-directed medical therapy to retard progression. And if you look at the studies and the body of evidence that's out there to support guideline-directed medical therapy, it's huge, whether for ACE inhibitors, beta blockers, aldosterone antagonists, angiotensin receptor blockers. Nitrates and hydralazine are commonly used, but this is essentially an add-on therapy other than in the Afro-American patient population, where again it's a class 1 indication in that population in addition to ACE inhibitors and angiotensin receptor blockers. Certainly mineralocorticoid receptor antagonists, eplerenone and spironolactone. There's a huge body of evidence now. Emphasis has really opened the door that these drugs need to be deployed in class 2 patients as well as the prior indications and evidence that was there in class NYHA class 2 and 3. So there's a huge body of evidence now on mineralocorticoid receptor antagonists. I'm going to skip this slide on heart failure with preserved ejection fraction. I know this will be covered, and TopCat, etc. So these are the recommendations for heart failure with preserved ejection fraction, and I'm sure this will be covered subsequently. So let me just mention a few things related to cardiac resynchronization therapy, and I'll just make one sweeping statement, and that is that cardiac resynchronization therapy, I believe, has been one of the most impactful treatments I've seen in the last decade. And I say that because it's one of the few therapies that we have, in addition to beta blockers, that can result in complete reverse remodeling of a patient with severe LV dysfunction. And any heart failure doctor could show you dozens, if not hundreds, of cases of patients with ejection fractions of 10 to 20% and dilated ventricles that within a year or two between medications and CRT have sustained and complete recovery of their ventricular function. So historically, ironically, when we first learned about cardiac resynchronization therapy, we really opened it up to a significant number of patients. And ironically, we've actually reduced the number of patients and tightened up the guidelines, if you will, in that the major benefit is seen in a patient with a true left bundle and a QRS greater than 150 milliseconds. It's actually the patients between 130 and 150 where, if anything, the level of evidence was downgraded slightly from what it was 5 years ago in that particular population. So what you see right here is EF less than 30, QRS 150, left bundle branch block, NYHA class 1 even, it's a 2B indication. But if you come up to level 1 indication, it's 35%, 150 milliseconds, left bundle branch block, and sinus rhythm. And things like 120 to 149 are now a 2A, and if it's a non-left bundle branch block, it drops down to 2B. So we certainly give, I think, a bit more thought and reservation to the use of CRT now than we did 10 years ago, based upon the greater knowledge base that shows us which patient populations tend to have the greatest amount of reverse remodeling. Non-pharmacologic therapy, there's nothing particularly glamorous about it, but it's a fundamental cornerstone of treatment. And again, I want to emphasize the growing recognition that we now have of empowering our patients, engaging our patients, educating our patients in their own self-care. And I don't know if BNP is ever going to be like a hemoglobin A1C, that patients are dosing themselves with diuretics, but some believe that that's the case. And certainly with some of the newer pressure monitors, patients can actually see their left atrial pressure and make a decision about taking a diuretic based upon that information. So moving into new therapies, ivabradine. Ivabradine is a very interesting drug that's been available in Europe for about 10 years. It inhibits hyperpolarization activated cyclic nucleotide gated channels. This is a so-called funny current, and this drug was promoted scientifically by Carl Svedberg, who led the SHIFT trial that was published in Lancet a few years back. This drug has not taken off widely in Europe. Recently, as of I think May or April of this year, it was approved in the United States, and it was approved with the indication to reduce heart failure hospitalizations, and the package label says that it can be considered in patients that are maximally treated on beta blockers that still have a heart rate over 70. The challenges that we face are that the drug is expensive at this point. We have made an initial review of our databases at the Cleveland Clinic, and you may be surprised what I'm going to tell you, but when we have patients come back for their 7-day visits, probably in the range of certainly less than, well, I should say at least 25% of patients are not on a beta blocker when they come back 7 days. And I think this is related to a very old patient population being admitted to the hospital that has their beta blockers put on hold. And the whole point behind this drug is not to use it as a substitute for a beta blocker, except in patients that have true beta blocker contraindications, such as bronchospasm, but to be added to a patient on a maximally tolerated dose of a beta blocker. So we're actually planning a clinical trial. I don't know if it will occur, but we want to test the hypothesis if this drug can actually reduce readmissions in patients with tenuous heart failure where the clinician has reservation about uptitrating the beta blocker because of the tenuous nature of the patient. So more, I think you'll be hearing in the next 5 years, but this drug is now available in the United States. Lastly, the newest drug that was just approved in August in the United States, that went to the FDA in February for a rapid review, which gives the FDA 6 months, is a so-called angiotensin receptor neprilysin inhibitor, or ARNI. And this drug is manufactured and owned by Novartis. The brand name is Entresto. It was known as LCZ 696 during clinical trials. So what is this drug? So this is a combination drug that includes valsartan, an angiotensin receptor blocker, and sacubitril, which is a neprilysin inhibitor. So by inhibiting neprilysin, which naturally results in degradation of natriuretic peptides, which are felt to have beneficial effects in the setting of chronic heart failure, this is what makes this a unique drug. So a clinical trial was done that was known as Paradigm HF. This was presented last September 2014 at the ESC, published in the New England Journal. There have probably been a dozen additional studies that have now come out. And the bottom line on this drug is that in chronic heart failure, when added to patients on beta blocker and ACE inhibitor or angiotensin receptor blocker and mineralocorticoid receptor antagonist, there was a 20% reduction in mortality and a 20% reduction in hospitalizations. The challenge is that the drug is expensive. There was just an article last week in the Wall Street Journal where an analyst came up with some sort of a formula that this drug was overpriced by I think 17%. So we are trying very actively to get this drug into the hands of our patients. We believe that the data and the science is very solid. I was the U.S. national country leader, so I was involved in the clinical trial. But I know that Novartis is working with the federal government and Medicare on a pricing scheme to see how this drug can get into the hands of many patients that may potentially benefit from it. The major challenges are hypotension, and the drug has to be very carefully uptitrated, much like we did with beta blockers when they first came out. And we have additional clinical trials planned in more ill patients. The drug is approved in the United States for NYHA class 2, 3, and 4. However, in this 8,000 patient study, there was 70 patients that were NYHA class 4. So the number of patients that have been studied to date in NYHA class 4 is small. Finally, there are a number of ongoing clinical trials. I'll concentrate on the reduced ejection fraction. So at American Heart Association, there will be a presentation on liraglutide, which is a diabetes drug. It's injected. This has been tested in 300 patients with systolic heart failure. You already heard about Innovate HF, which is vagal stimulation. That trial is closed to enrollment. It's fully enrolled. There's another clinical trial looking at oral iron therapy, another one with aliskiren, and guided, as I already mentioned, is a BNP-directed trial. So in summary, establish the clinical diagnosis, know the phenotype, know the underlying etiologies, treat the reversible causes, look for the precipitating causes when the patient comes into the hospital. It's not just about diuresis. Education is essential. Guideline-directed medical therapy is the cornerstone. New interventions, including ivabradine, Entresto, and implantable hemodynamic monitoring, I think are on the future. And each individual patient, and there will be another presentation on this as far as needs a discussion on defibrillators. Thank you very much.